Xavier Lelex, Poitiers, France. I would like to thank you, the chairperson, for very nicely introducing me. And it's my great pleasure to share our experience with the CAR T-cell technology and how amazing should be the benefit you will have for your patients. Next slide, please. Here are my honorariums. So next slide, please. So you know that the target that we use these days to use the CAR T-cell technology is BCMA, B-cell maturation antigen. On the upper left side of the slide, you can see that BCMA is a receptor largely, almost essentially expressed on plasma cells. It is expressed on other organs, but the difference in expression is huge in plasma cell compared to the other organs. The BCMA is a receptor for two ligands, APRIL and BAFF, that is used for the survival of myeloma. Interestingly, when you target BCMA, you block this signaling pathway for the survival of myeloma. We will talk about that in a minute, but BCMA is essentially expressed on plasma cells and also on pre-plasma cells in the ontogeny of the B-cell lymphocyte. Next slide, please. So BCMA is very highly expressed in plasma cells, but starts to be expressed in a pre-plasma cell in the last stage of the B-cell lymphocyte. And that explains why normally if you target BCMA, you will have a complete destruction, disappearance of pathological plasma cells, myeloma plasma cells, but also normal plasma cells, and for some patients also be a lymphocyte. Next slide, please. So for a CAR T-cell therapy to succeed, you need to start with a tumor antigen exclusive as much as possible to the malignant cells, and you need to try to minimize, to mitigate as much as possible the clinical off-target consequence. Next slide, please. So there are many targets that could be used as very much specific to the plasma cells. Today, we talk about BCMA targeting CAR T cells, but you should know that there are other CAR T with other targets in development, and for example, GPRC5D, but not only. This is a reminder that BCMA mRNA expression is present in many cancer, but again, cancer that are related to plasma cell, essentially myeloma, are largely on top. Next slide, please. Today, we're going to talk about the current generation of CAR T cells that are on the market, commercialized. But it is true to say that there is an incredible development around the CAR T cells, and none of these incredible development that will come in the future is yet available for the CAR that we are going to discuss. Next slide, please. However, the CAR that we are discussing today is what we call a second generation CAR. The two CARs, ide-cel, Abecma, and cilta-cel, Carvykti, belongs to the second generation CAR T cells, meaning the SCSV on top of the CAR of the cells, then the cell membrane portion with the transmembrane domain and the co-stimulating ligands, and then the endo domain with the rest of the co-stimulating factors. CD3 zeta and 4-1BB are the constructs that we are going to talk about today. Next slide, please. So today we have largely access to ide-cel in many countries in the world, and an increasing access to cilta-cel. However, not for all patients. And so we're going to discuss sort of the need to select a bit the best patient for the CAR T production. Next slide, please. So the first data and the most mature data we've been working with come from the CAR-MMA trial. CAR-MMA is the name of the program of all the clinical trials that have been developed with ide-cel, the CAR-T coming from Abecma. That is, and you see in the upper right part, that is a regular CAR, second generation, with the scSV that is mouse. So chimeric, but mouse, not fully human. The rest is as I've been discussing. You are going to try to leukapheresis enough cells so to ideally reinject 450 10 to minus 6 cells. If you can do so, there's a great chance that your patient will sit in the upper curve of the figure in the bottom right panel, with a great likelihood to get a profound response, eventually MRD, negative status, and a prolonged control of the disease. Next slide, please. There's another CAR-T, cilta-cel, Carvykti. The name of the program for the Carvykti development is Cartitude, and the first study performed in very advanced myeloma, end-stage myeloma, was called Cartitude-1. This study is very much known because it was really, really unprecedented in the matter of data provided by the company. Cilta-cel, you can see again the little figure, the little picture on the top right-hand part of the slide, is different from ide-cel. It is a second generation, and globally the construct is the same. However, the scSV is different. There are two binding domains for BCMA when in fact ide-cel has one. And the production of ide-cel is essentially ex vivo, while the expansion of the CAR for cilta-cel is in vivo. And we will see that has a consequence to the patients. The results of cilta-cel were absolutely incredible. In Cartitude-1, patients very advanced in the disease, almost refractory to everything, with a survival that is counted in less than a year. The chance to respond was 100%. The chance to reach a complete response was close to more than 90% of the patients. And the median progression-free survival, death or relapse, was at almost 3 years, which in that population has never been seen with any drug before cilta-cel. So it is fair to say that cilta-cel seems to be better than ide-cel, although ide-cel is incredible. Cilta-cel seems to be better. Next slide. The most recent data provided last year at ASH, American Society of Hematology, and this year at EHA and ASCO, confirmed what we knew of cilta-cel in very advanced end-stage myeloma, heavily pretreated patients, that the median PFS was approximately 35.9 months. And if you had reached complete response or even better, MRD negative status, most of the patients, by the way, you would have a median PFS not reached, meaning gonna be better than 3 years. Next slide, please. So what is new in 2023? Because what I have shared with you so far was actually something we already had discussed before and was known. Next slide, please. So there has been a lot of real-world data in the left-hand side with ide-cel, in the right-hand side with cilta-cel. Real-world data important because we know that when we recruit in clinical trials, we highly select the patient, and the idea was to make sure that in real-world data, we would be able, with patients that sometimes much more difficult to treat and that would never have entered a clinical trial, that we would replicate the data from what data we have obtained in the clinical trials. And that's exactly what you can see here, is that ide-cel appeared absolutely superimposable, even actually almost better in real-world data compared to CAR-MMA1. And for cartitude cilta-cel, in real world, it's the same. A very interesting data, very positive, replicating what we knew from the clinical trials. These patients were truly end-stage myeloma in these two real-world studies. Next slide, please. So the point that I really want to share with you is that to offer a CAR-T ID cell or cilta-cel to a myeloma patients is going to provide to you, physician, and to your patient and their family an incredible benefit. Once we have said that, it is true and fair to say that the earlier you're gonna offer the CAR in the disease course of the patient, the better will be the benefit to the patients. And we have two studies reported in 2023, CAR-MMR3, CARTITUDE-4, next slide please, that have confirmed that if you could do the CAR earlier in the disease course, in less advanced lines of treatment, then the results will be much better. In CAR-MMR3, third line or fourth line, the results were pretty impressive. Again, the median PFS in the bottom left-hand side of the figure of the slide is the median PFS is only 13.3 months. Disappointing in a certain, but that's for all comers. If you look at patients in complete response or even MRD negative status, then the results are much, much, much better. What we have learned with the CAR also is that you need a bridging therapy between the leukapheresis and the reinjection. We call it the vein-to-vein time. You need to control myeloma disease. And for some patients, maybe even before the leukapheresis, you will need a treatment to control myeloma, to optimize the cells you're going to collect for the leukapheresis. Let's call it induction. So we'll come back to this. What we have learned from CAR-MMR3 is that the safety profile was quite impressive. Cytopenias, but we'll come back to that. Cytopenias after the injection, certain patient with infection, CRS, cytokine release syndrome, right after injection for ID cell within hours, for cilta-cel around day 5, 7 within days, but very manageable. Next slide, please. So we had the data from CAR-MMR3. We have the data for CARTITUDE-4, second line, 2 lines, 3 lines, 4 lines of treatments, early relapse, multiple myeloma CAR-T program with cilta-cel, and the results, as expected, are even better than ID cell, not only because the control arm performed better, but also because the CAR-T did even better. Next slide, please. Same thing, the safety profile was acceptable, not very different across CAR-T, cilta-cel, and ID cell. However, slightly more Parkinsonism syndromes, so late neurotoxicity compared to ID cell in cilta-cel. This graph, I wanted to show that graph to you because it shows very nicely how much, even if you have cilta-cel, probably the best CAR we have out there, but even with the best CAR, if you do the CAR earlier, you will always improve the patients. Next slide, please. And so this is important to remember. If we talk about, I'm going to do my CAR for my patients, but then how can I, the patient's going to ask worldwide, and makes sense. A patient would ask a doctor, tell me, how can I know if my CAR succeeded? How can I guarantee my CAR is going to succeed? You never guarantee a CAR is successful. However, we now have tons of data to say that if the patient had a normalized BCMA soluble serum concentration, these patients are the patients who do better. Next slide, please. And similarly, if you reached MRD negative status, these patients are the patients who do much better. So again, let's conclude this part here. If you have a patient that reached MD negative status, you cannot guarantee that the CAR-T will be successful for years and years, but definitely it is an excellent situation. Same thing for the soluble BCMA marker, although I don't know if truly we need to monitor the soluble BCMA because we can monitor the MD. So we don't monitor soluble BCMA. We do monitor the MD by marrow and PET-CT for our patients, but I'm happy to answer questions on this if you wish to. Next slide, please. So where are we going in 2023 and for 2024? We are recruiting in patients newly diagnosed in the CAR-MMA program and in the CARTITUDE program, CAR-MMA 9, CAR-MMA 5, CAR-MMA 6 in transplant and non-transplant recipients, candidates, with different questions. For non-transplant, the question is, can we give an induction and then the one-shot CAR and the patient is off treatment with an excellent, hopefully, quality of life and control of myeloma disease. For transplant patient, the question is, can we replace transplant or can we transplant and give a CAR, sort of replacing the tandem transplant? Other questions, maybe we should get rid of maintenance and give a CAR instead of the maintenance. There are plenty of questions, and we'll see in the next years how all these studies will pan out and what data we will get and how we will change our practice from there. Next slide, please. The one thing I believe that you will be really most struck with, and the one thing I have been most struck with, is the quality of the patient, which is absolutely incredible after day 1, 2, 3 for the patients until they relapse. And I hope you'll have the same experience. Next slide, please. So again, and I'll finish the first part of my talk here with this conclusion. Locomotion is one of the real-life study of what you can get in terms of survival for a patient if you do not use a CAR. And you can see it's absolutely terrible, 4.6 months median PFS, 12 months median OS, overall survival. So clearly the CAR will transform your practice compared to before you had a CAR. We also face an issue in myeloma, is that when you have used daratumumab or isatuximab anti-CD38, and your patient is refractory, reusing the other one, so you had daratumumab, you're going to use isatuximab or vice versa, doesn't work. We know it doesn't work now, or it worked poorly. You can see on the right hand a study that we have conducted with Joe Michael from Los Angeles, and Joseph and I, we have demonstrated that one anti-CD38 followed by the anti-CD38 was not very much active, particularly if you're refractory to the first time you were exposed to an anti-CD38. So we need new drugs. So you will have the anti-BCMA, anti-CD3 bispecific, and the anti-BCMA CAR-T. Next slide, please. Now, we still have things to look into. Next slide, please. Not everything is genius. It is genius, but not everything is genius. First of all, there are patients, and you can see on the left-hand side and the middle column, you can see that some patients have a poor response. Some patients do not reach complete response, MD status. These patients in the future, we need to improve. We need to understand, is it the quality of the cells we have leukapheresed? Is it that when we re-injected the CAR, it was not active? Or was it the CAR-T product that was not that good? Or was it an excellent result of the CAR, but because myeloma is high risk, the patient relapsed still earlier than expected? So we still have to answer the question, why do some patients not succeed to the same extent as the other? And we know that for very high-risk myeloma, where we are desperate offering a new treatment, you will see that it is not, these patients are not the best candidate for CAR, because you hardly control the tumor mass before leukapheresis, you hardly control the tumor mass in between vein to vein time, and even when we re-inject the CAR, And even if the patient reach MRD negative status, they tend to relapse after 6 months, 1 year, or 2 years. So it is important to know that you can offer a CAR to high risk, but it is not necessarily the best candidate. Next slide, please. And you have an excellent, and I'm going to be quick on this slide, you have an excellent depiction of what I've just voiced, coming from the study called CAR-MMR3, where you can see that the CAR was 13.3 months median PFS, but whatever the definition of high risk genomic, revised ISS high tumor burden, extramedullary plasmacytoma, triplet class refractory, each time you go by a high-risk population, a poor risk population, a poorer risk population, you will see that the CAR is doing not as great. Indeed, any other treatment do even more poorly, but the CAR not necessarily is the best patient. So if you think about high risk, really the earlier you will CAR the patients, the better. If you think about triplet class refractory, maybe we should have CARed the patient when the patient was triplet class exposed rather than refractory. If there's a high tumor burden, maybe you want to debulk as much as possible, so earlier in the disease course, so you can have more option to debulk before you CAR the patients, etc. Next slide, please. It is clearly demonstrated that the more the tumor mass, and I'm not talking about high-risk genomic here, I'm really talking about 50 grams per liter, 5.0 grams per deciliter of M-spike. It is not necessarily poor risk, it is high tumor mass. So the higher the tumor mass, the more likely the product you're going to look at for us will not be as great, and the CAR injected will not be as great. To make it simple, you're going to exhaust your CAR to debulk rather than exhaust your CAR to put the patient in MRD negative status. So it is important to control myeloma with any other treatment, daratumumab, pomalidomide, carfilzomib, bortezomib, lenalidomide, etc., before you leukapheresis induction, before you reinject, bridging therapy, vein-to-vein treatment. Next slide, please. So it is important to reduce the tumor mass. Next slide. And in my practice, my colleagues might criticize, but in my practice, I select the myeloma patient in the relapse setting according to existence of a potential treatment to control the tumor mass prior to apheresis and to control further the tumor mass in between apheresis and reinjection. If the patients have no treatment available, I do not CAR the patient. I offer these patients a bispecific. And I regret that the patient were not sent to me earlier. But if a treatment is available, bortezomib, pomalidomide, dexamethasone, even a venetoclax-based treatment, daratumumab, isatuximab-based treatment, carfilzomib-based treatment, but if there is a treatment to control tumor mass for the myeloma disease, then to me, it's a perfect myeloma candidate. In Europe, we can do CAR after 4 lines. So, no, sorry, after 3 lines, 4+. But we do the CAR often at 3 line plus. So we have more option to treat myeloma to control the disease, and also because at 3 line plus, it's already very late to do a CAR. So the earlier the possibilities, the better the better candidate is a patient for CAR. Next slide, please. We have demonstration to that. The CAR-MMR2 program and the CARTITUDE-2 program have looked into patients first line and in second line, and we can see how better are the results. And I picked here the ID cell, the CAR-MMR2 as an example. CAR-MMR2 C2C were corresponded to patients that were post-transplant upfront, not responding very well to the transplant. So technically speaking, poor risk. And in fact, if you look at the CR rate, you can see it's 74.2%. In the CAR-MMR3, in CAR-MMR3, it was below that, and in CAR-MMR1, it was 30%-ish. So even if the patients are higher risk or poorer risk, if you move the CAR earlier and potentially one day up front, you will improve these patients. And maybe at some point, I will come here and say, even for high risk, CAR-T works very well because we have found the best timing to do the CAR. So the earlier, the better. In Europe, we can do at 3rd line. So it's better to do at 3rd line instead of 4th, or 4th instead of 5th. Next slide, please. And so that slide, this slide shows exactly what I'd explained. Next slide, please. We need to improve the car product. Next slide, please. So there are various ways to improve the car product. And actually, because the physicians and the scientists, more importantly, are quite genius, there are like a million options of how to improve the car product and the patient, etc. And there are lots of science in looking into trying to do things better. But one thing you need to remember is that, and I think there is no reason it would be different for Saudi Arabia compared to France, which is that when you look after your patient, the time it takes for the cells to come back to your center, the vein-to-vein time, right now in France, it's 2 to 2.5 months. So one thing we wanted to improve is to make this turnaround for the cells to come back to the center and be reinjected much shorter. Novartis, with this PHE885 product and this new way of CAR-T, of doing the CAR, the T-Charge platform, have demonstrated, next slide please, that not only they can enhance the number of CD4 and CD8 that are T cell memory, less in exhaustive shape, more in pre-exhausted, more in active/naive status. So not only they can enhance this number of cells, but next slide, please, but also the turnaround is very short. I was very, very surprised. In 8 days, 1 week, I got my cells back. This was incredible because I was used to 2.5 months. I was used to 8, 9, 10 weeks. And with this product, it came back in 1 week. So we'll see if that has positive consequence to our patients, our practice, and the quality of the CAR. But if that turns out to be very positive, then it's going to be a great plus. And so far, my gut feeling is that maybe this Novartis product is as good as a cilta-cel, but the turnaround is much shorter. So hopefully this will conclude nicely. Next slide, please. There's a lot of future direction, and I'm not going to spend time on this because for the sake of time and because I want to discuss to my last third piece of my talk. Next slide, please. So CAR-T is a team effort. CAR-T needs patient selection, and CAR-T needs patient and team education. Next slide, please. So one thing that was very nice with the CAR is that we have created a coordinating team for the CAR to help us manage a patient that we sometimes never known before, to meet the patient, explain the patient, educate the patient, reassure the patient, organize leukapheresis with the pharma company and our leukapheresis team. Then organize a bridging therapy in the original center, community-based center, or in our center. Then the cells are back. We know the cells are back. The pharmacy, the central pharmacy, now the cells are back. And we're all aware that the cells are back. And we can move on with the next step, which is lymphodepletion, a bed, hospitalizing the patient, organizing what is needed for the lymphodepletion, and then a special nurse on the day of the reinjection. And then the patient is hospitalized to monitor the CRS, cytopenias, risk of infection, potential neurotoxicity side effects, and then the patient is released, but we need to continue monitoring the patient. It needs a team effort, and it is something that is great because it's always good to learn to now how to work as a team and not always as a physician facing a patient. Next slide, please. I'm not going to spend too much time on side effects. The number one side effect you want to monitor is the cytokine release syndrome. With ID-cell, it happens, it develops within hours. You reinject at 11 a.m., starting 2, 3, 4 p.m., 6, 8 p.m. in the night, in the next night, you may have a fever that will develop. Most of the time, very well tolerated fever, but fever. Grade 1, Lee classification of CRS. If the patient starts having hypertension, feeling worried, etc., you probably changing to a grade 2, and it's not good. We monitor grade 1 Lee classification CRS. But if it lasts for very long, if the patient maintain at 40 degrees Celsius, 41, then we treat even a grade 1. We don't wait for the grade 2, because if you wait for the grade 2, then you may lose the control of the CRS. So when the CRS grade 1 lasts for hours, we treat. You can treat with tocilizumab, anti-IL-6 receptor immunotherapy. You can treat with tocilizumab plus dexamethasone. You don't want, with a CRS from a CAR-T, to treat with dexamethasone only. You do not want to give dexamethasone only, either toci or tocidex. Dex, 10 milligram. And then you monitor. Maybe the CRS will resume the next day, and either you monitor or you retreat. It's not very good to give tocilizumab every hours. It's probably better to wait 6, but even more, 12 hours before you do again a toci injection, because at some point you inject toci, but it's not working at all. The cytopenies that are following the lymphodepletion, the CRS storm from the bone marrow, and maybe the CAR rejection, etc., on a poor marrow reserve, last for a month. They could be very profound. Sometimes they last for more, but they are rarely complicated by bleeding, anemia issue, or infection for the neutropenia or lymphopenia. So stay calm, even if the cytopenies are very profound. And of course, you take care of the patient with all the supportive care you know of, but I'm happy to discuss this in the question part. Icons, confusion, very high fever, can happen. The treatment is a treatment of the CRS. Parkinsonism syndrome, I'll discuss this in the question part. Next slide, please. Infection is rare. It can happen, it is rare. If you give polyvalent immunoglobulin, the patient will improve. If you prevent pneumocystis, herpes zoster, and upper respiratory infections, particularly in Europe, maybe less in Saudi Arabia, but particularly in Europe, you will sort of prophylactize the patient against this type of infection that can develop within the first weeks, months after you have released the patient, because of the profound cytopenia induced by the lymphodepletion, the CAR, the poor marrow reserves, etc., the cytokine storms and the CAR, etc. So infection is something you want to monitor. Infection is not something you want to worry about. Next slide, please. It's actually great. It's actually very interesting that, oops, there is a problem with my right-hand figure. It has shifted. It should be a quarter of turn on the left, but doesn't matter. What we were showing here is a very interesting work published now that showed that we feared the risk of infection. And I'm not saying the risk of infection is not present in myeloma under CAR-T program. It happens. But you can see on the left part of the slide that it decreases, the risk decrease, the incidence decrease over time with the CAR. While on the right-hand side, normally what you should be seeing is that with the B-specific, the risk not only exists from scratch, but also increase over time. And it takes some time before the risk of infection on B-specific sort of stabilized and decreased. So I'm not saying you will not experience infection with the CAR. I'm saying that you should not experience much infection or potentially even no infection. Still, you need to monitor. Next slide, please. Extramedullary disease, plasmacytoma with myeloma, either bone plasmacytoma, PMD, paramedullary, or soft tissue, other organ plasmacytoma, EMD, extramedullary disease. This is terrible. The prognosis of these patients is crazy, very poor. And the benefit of the CAR is limited. Often, the CAR will wipe out these plasmacytomas, but they relapse within 6 months, a year. It is not a reason not to give the CAR. It's fair to say that we need to find a way to improve the CAR, potentially by giving other treatment after the CAR injections to strengthen the effect of the CAR for these patients. This is a poor prognostic marker. It will remain a poor prognostic marker even in patients that had a CAR. Next slide, please. If one of the problems of the CAR, and I'm almost done in my talk here, is that some of the patients cannot get a leukapheresis. Some of the patients had been leukapheresed, but cannot be re-injected. If you treat the patient earlier, you'll stay away from this really crazy situation. If the later you CAR a patient, the more it'll take time for a patient to be CAR, the more likely you may experience this very sad situation where the patient wants you want, but you fail. And so, again, as I've said again, most important piece of my talk here is that the earlier the CAR, we CAR in third line. We give a treatment to control myeloma. Once myeloma is controlled, we leukapherese. We continue the treatment to control myeloma, and then we re-inject the patient. We completely stop the treatment to control myeloma because a CAR is a living drug, is the new treatment. And then when we re-injected the patient is doing great. This is the greatest situation to CAR patient. This is the most, I would say, the word is not coming to my mind here, but it's very reassuring. It's really great to see the patient improving if you do things this way. Next slide, please. The bridging therapy, next slide, please. You can give any drug you want. There is no demonstration today that one drug is better than another, but you want to avoid giving an anti-BCMA. Do not give an anti-BCMA, even probably an ADC. Probably ADC, anti-BCMA, for example, belantamab mafodotin, antibody drug conjugates, BCMA targeting. Probably you could give that and it will not hamper the activity, but you want to stay away from that, if you can. But then giving an anti-CD38, daratumumab, isatuximab, lenalidomide, pomalidomide, proteasome inhibitors, carfilzomib, bortezomib, or even venetoclax, it doesn't seem to be really a problem. At least today, we have no demonstration that it creates issues in collecting or reinjection or following the patient. Maybe in the future, we'll be able to have a better view of that. But right now, the most important thing is avoid myeloma progression before leukapheresis and before reinjection. Or if myeloma progress, it should be slow. It should be limited tumor burden increase. But massive radiorapid tumor burden increase prior to leukapheresis, and prior to reinjection is really what you want to avoid now. Next slide, please. So then there is no great and bad treatment. You want to avoid also corticoids. You want to avoid alkylating agents because you want to avoid the risk of infection once you have lymphodepleted your patient and re-injected your patients. But again, as I've said, besides saying this, the most important aspect here is control of myeloma before leukapheresis, before re-injection. No drug is considered better or worse. No anti-BCMA if possible, no alkylating agent if possible, no corticoids if possible. Next slide, please. I'm almost done. Next slide, please. We are learning now a lot of things on resistance to CAR. As I've said, patients may not respond or poorly respond. As I've said, patient may relapse earlier, 6 months, 1 year, very disappointing. As I've said, high-risk myeloma are less responsive than very good risk, standard risk myeloma. So there are reasons to that, resistance to the CAR, either because of the CAR, because of the target, because of antibodies against the CAR, because of cells fitness of the CAR that you have collected, or even what we call an immunosuppressive, non-permissive microenvironment. Next slide, please. This is something you cannot study, and even the immune mechanism of resistance. This is not something you can study in real life, routine practice today. It is something a lot of teams are working on to determine markers that will be needed or necessary to study in the real life. Today, this is science. There's nothing that I can say, you should do that or you should do that, because we don't know. Next slide, please. What we do, though, we do a marrow before apheresis, and we monitor the control of myeloma, and we know the complete genomic, ideally complete genomic, of our patients. And we also do a flow cytometry appreciation of whether in the blood of the patient, the T lymphocytes are showing a lot of exhaustion markers. We also do the same exercise in the blood, in the marrow, before we do the lymphodepletion, and a PET-CT to have an appreciation of existence of extramedullary disease, plasmacytomas, etc. Then we do the lymphodepletion, we re-inject the patient, and we try to study in the CAR product the quantity of cells we re-inject, the quantity of cells that are CAR in the CAR product, and the exhaustion marker in the CAR product. And then we monitor that in the patient after the re-injection at months 1, 3, 6, and 12. Besides this, there is nothing I can tell you that would be better, worse, etc. Still ongoing work. Next slide, please. So, well, I think we can conclude saying that novel immunotherapy, the CAR T cell and the B-specific T cell redirecting with BCMA as a target are going to bring a sun, and well, you have a lot of sun in Saudi Arabia, but will bring even more sun in your life and the life of your patients. And I think this is my last slide. And I guess with this, I'll thank you very much for your attention, and I'm open to your questions. Next slide, please, just in case. Yeah, that was to say that there is a new target, GPRC5D, but it was just for the sake of concluding. Next slide, please. Then that should be my bird. Voilà. Thank you very much for your attention.